Hello, and unless you've been on a distant planet, you will know that the big story in all the newspapers and everywhere has been coronavirus. There's been a lot of stuff written about it, a lot of bad stuff written about it, a lot of public hysteria and everything. I'm here today with my very good friend Dr. Michael Brooks, who is the Chief Medical Officer of PatientSource and also an emergency medicine doctor, to get the facts and to drill down. Can I start with question one, really? With HIV and with the Spanish flu, that killed about 50 million people. With those being high on a scale of 1 to 10, where do we place seasonal influenza and where do we place COVID-19?
So it's a good question. So I think let's have a look at what HIV and Spanish flu did, and then let's compare it to what we know so far with your coronavirus, COVID-19. So HIV at the moment has infected about 40 million worldwide. That's your prevalence. 40 million people have got it. Because we've got good stats on HIV, we know that there's about 21% of those don't know they've got the diagnosis. We've got treatment for HIV. You live a normal lifespan if you put on highly active antiretroviral treatment. And so the death rate is about 770,000 per year. Overall, 2% of the people who are infected with HIV will die each year, and across the whole globe, where you've got 7.8 billion people, that's basically 0.0099%. So what's that? 1 in 10,000. So that's your HIV. I'd call that an 8 out of 10 because we've got treatment for it and its mortality is relatively low. If we look at Spanish flu, this raged in January 1918 to December 1920, so almost 3 years. At the time, there were 1.9 billion people in the world, and Spanish flu infected 500 million of those. So that's more than a quarter of the global population were infected by Spanish flu. Now, of course, medicine wasn't as advanced in those days, so the mortality rate was actually pretty high. We saw up to 20% of the infected people dying of Spanish flu. So it wiped out between 40 and 100 million people. In other words, 2 to 5% of the entire globe was wiped out by Spanish flu. And one of the curious things was more lives were lost in young people because older people had met in 1895 the Russian flu and possibly got partial immunity. So here was something that humans hadn't seen before that raged through the world and wiped out a significant chunk of the population. That's a 10. Now, if we look at coronavirus, so at the time of filming this, I think there's about 102,000 cases that have been confirmed. So, already that is a tiny fraction of the world population, 7.8 billion, so that's 0.0012% are infected. Obviously, that doesn't include those who don't know they're infected because this is just tested cases. Of those, 3,400 have died. So your mortality rate is 3.4% of the infected, and the infected is 0.0012% of the world. So this is a much smaller proportion of people infected, and of those, a smaller proportion compared to Spanish flu died. Spanish flu up to 20%, COVID-19 up to, there's reports up to 6%, but we know now it's settling out about 3.4%. So I would say coronavirus is a 4 or a 5, probably a 5 because there's a lot of unknowns. So Spanish flu was at 10, HIV is an 8, very important problem. I think coronavirus in the grand scheme of things, probably a 4 or a 5.
Thank you. I've heard it compared a lot with seasonal flu. How does COVID-19 compare with most of the seasonal flu outbreaks that we see every year?
So I think when we're looking at seasonal flu, we just need to be aware we are sort of comparing apples and pears, right? Because seasonal flu is the influenza virus, a very different type of virus to a coronavirus. But that said, they're both respiratory predominant infections, and there are similarities between how they present, how they are spread, how the vulnerable groups. So in the case of seasonal influenza, that's generally going to infect between 5 and 10% of the population per year. So usually in the winter, 5 to 10% will succumb to seasonal flu, as in will get infected. We've already spoken about it, coronavirus, COVID-19 is 0.0012, a lot smaller. Duration of outbreak, usually an influenza season lasts 13 to 14 weeks. For COVID-19, we're in, I think, the 10th or the 11th week now. We don't know how long it's going to last. It might be similar, it might be longer. For flu, you've got an incubation period of usually about 2 days. It's pretty quick. You get infected, 2 days later, you've got your symptoms. COVID-19, we know from a study that was done in the early cases in China that incubation periods were as short as about as short as 2 days, but could go all the way up to 14. Most of them were between the range of 2 and 7. The median was 4 days. So it's a bit longer, the incubation period. Hospitalization rate for influenza, about 1%, 1 in 100 of those that get the infection need some form of hospital treatment, usually oxygen therapy or sometimes ventilatory therapy. Now, if we compare that to COVID-19, the hospitalization rate, we don't have good stats on. And because we only know about confirmed cases, the hospitalization rate probably looks higher than it actually is. The worst case report is from those early cases in Wuhan and suggests about 20% either need oxygen or ventilation, stuff that you need to do in hospital. So 20% of the infected, but that's the worst I think we're going to get to. Symptoms are similar: cough, fever, aching muscles, sore throat in some cases. One thing that does stand out in COVID-19 is that if it does progress to the pneumonia, the chest gets down to your chest, you see a lot of, you see people coughing up sputum. You don't tend to see that in influenza, it tends to be dry. So, you know, on the whole, COVID-19 affects fewer people, has a higher mortality a bit, probably a higher hospitalisation rate, longer incubation period, looks the same symptom-wise.
Can I pick up quickly on this idea of COVID infecting fewer people? Because one, we've seen very extreme containment measures, particularly in China, but in Italy we've seen villages shut off. We don't do that with influenza.
No, we don't, and I think part of the reason is that, first of all, influenza has been around humanity and happens every single year, so there's a certain background immunity to it. That kind of dampens the fire down. There's a lot of unknown, and where there's unknown, you kind of have to plan for the worst case scenario. So I think that's one of the reasons why COVID-19, they've been more aggressive about containing it. I think the major reason, though, is if you look at the statistics, your average influenza case an average person with influenza will infect 1.3 others. Or if we get 10 people with influenza, then they will go on to infect 13 others. In the case of COVID-19, one person infects 2.2. So if you've got 10 people with COVID-19, they will go on to infect 22 others. So that is significantly higher. And that means you've got this potential for this exponential spread. So I can see why you'd want to contain it more aggressively.
And I guess if that number is less than 1 with any particular pathogen, then it would just die out.
It fizzles out to nothing, absolutely, yeah. And you know, there's many factors that might affect that, this propagation index. It's not just how the particular virus behaves, it's also how people respond to it. If you've got a virus that lays you in bed from day one that you've got it, that's going to be a lot less infectious than if you've got something that allows you to walk around for 2 weeks.
Yes, I suppose that's with Ebola and places.
Yes, yeah.
Pathogens like that. So if there are people who only develop mild symptoms, as we saw, for example, with patient 1 here in the UK, and they're just, or no symptoms at all, clearly they're not going to appear in the statistics. So could there be a lot more cases of this than are suggested by the official figures that we see?
I think absolutely. I think, so unlike the example I gave earlier about HIV, where we've got decades of stats and know how many people have got the infection, and then when we go retesting people, what proportion of extra people we find with the disease, you know, we can estimate the total burden there. We haven't got that for COVID-19, we just know the confirmed cases, but there's a big confound there. First of all, the test for COVID isn't great. It's got a limited sensitivity and specificity, so there's some false negatives and false positives. Secondly, people don't get tested until they've got symptoms, and some people with mild symptoms probably won't ever get tested because for them, this is another viral illness, it's going to blow over. So I think almost guaranteed we've got an underestimate, and I think the underestimate is probably going to be, a majority of it is going to be composed of mild cases. So yeah, I think we probably are underestimating the cases.
And when people are diagnosed with COVID, I guess we're trying to trace their contacts and test them, but we're not testing a sort of random pool of people within the population.
No, we're not at all. It's very much a whack-a-mole approach rather than a blanket screening approach.
So can this virus be transmitted by people who are asymptomatic, who are not presenting any symptoms?
Yeah. So this is we call viral infections, we say they have an incubation period. That's from you first encountering the pathogen to developing symptoms. Now, there's also the infectious period, and this may overlap the incubation period. So this, in the infectious period, you are now producing enough of the virus particles to pass it on to other people. In some viruses, there's hardly any overlap, but COVID, there is a significant overlap. We don't quite know how much, but we know the incubation period can be as long as 14 days. And we know that there is a significant proportion of that people are infectious for. So they're going about their daily business with not a symptom, and they're shedding virus and propagating that to other people. Then they come down with symptoms. So because of this lag, and because you might be walking around for a few days without knowing, this is why health authorities are worried about it being passed on. So
that brings us to the question of how COVID-19 is spread. Is it coughing? Is it fecal transmission? What is it?
So we don't know the full gamut of the different mechanisms because, once again, it's a new strain of a virus. We can model it, though, on very similar viruses. So you've heard of SARS and MERS. They are both coronaviruses. They're the same family of viruses. And they are predominantly spread by droplet infection. So that's, if I were a patient, I would, if I coughed or sneezed, I would eject virus particles into the air. And some of those might be breathed in by people nearby. And it's passed on that way. It might splash people's eyes. So droplet infection is probably a number one, but of course there's also the survivability of the virus. If those droplets land on a surface, I can then contaminate the surface with the virus, and people can then, if they touch that surface, have virus particles on their hands, and then they can then infect themselves from that. So the second method is what we would call contact. You basically contact a surface that's infected, and then you introduce the infection to yourself. There is a paper that has recently come out that's found the COVID-19 strains in stool, which suggests that the fecal-oral route is a possibility as well. So we don't know the full gamut. As far as we know, though, it doesn't penetrate skin and it's not bloodborne. So, you know, being splashed with somebody else's blood is probably not going to get you infected. There are other risks from that of other viruses, but not COVID-19.
Which is very reassuring. Now, I was in the supermarket yesterday. They'd completely sold out of bacterial hand wash, but surely that's not going to protect me at all.
So the bacterial hand wash, it is effective for COVID-19, but so is soap and water. And the thing about soap and water is it will kill some viruses that alcohol-based hand gels do not. Norovirus that you've mentioned is notorious. Alcohol hand gel does not destroy norovirus. The other thing about alcohol hand gel is it dries people's hands out. And if you dry your hands out, you then start to get inflammation of the skin. And so that your barrier against other organisms, not necessarily COVID-19, is depleted. So I would say it's generally better to use something like liquid soap and water, and more importantly, just wash your hands properly. So yes, they do help, but if you're going to the supermarket and you're going to reach for the shelf for something to reduce your risk of COVID-19, I suggest you go for liquid soap, because not only is it kinder to your skin, it's going to be effective to other viruses that you're more commonly encountered, and you'll have more use for it.
So we were talking earlier about how the droplets reside on surfaces. Do we have any information about, perhaps looking at similar viruses, how long they exist on particular surfaces?
So there's a paper looking at exactly this question. Again, it's from the SARS outbreak days, although there has been a review since. I think it was Kampf et al. Did a review of this year, actually. And they inoculated a surface with the virus particles, coronaviruses, SARS viruses, and then they measured how long it would be before they could no longer generate a viral culture from swabbing that surface. The upshot is, for most surfaces, it's 5 to 9 days. So it's quite a length of time.
So tell me, do viruses spread better in cold weather? Are they easier able to survive under those circumstances?
Oh, it's a really good question. It does depend massively on the virus and massively on the mechanism of spread. And there are some viruses where we kind of don't understand why we see seasonal peaks. The best example is the common cold. Most people will be familiar with getting the common cold in winter. But some people can pick up a cold in summer, and you hear people saying, I'm so unlucky, I've got a summer cold. Well, actually, they're probably two different viruses. Rhinoviruses predominate in winter, and enteroviruses, which can give similar symptoms, predominate in summer. We don't know why. Now, we know that they're both a droplet infection spread, so they've got similar mechanisms, but we don't know why enterovirus is summer predominant, whereas rhinovirus is winter predominant. The wisdom for rhinovirus is that in winter, People spend more time indoors. They are closer together because they're indoors. You've got colder air gets saturated more quickly, the humidity is higher. So the closer people are, the higher the humidity is, the longer, the easier it can transmit from person A to person B, and the longer the virus will survive outside the human body. So that kind of makes sense. In the case of COVID-19, we haven't got enough data to really know whether it's going to be seasonal or not.
What precautions do I need to take to avoid this? Should I be avoiding crowds? Do I need to wear surgical masks, surgical gloves? What?
Okay, so let's look at the stuff that works and the stuff that doesn't work. So the stuff that works, the big one is washing your hands properly, okay? Because probably the majority of infections are from you having droplets in your hands, touching your face, introducing them to your mouth or your eyes, etc. So getting into good habits of hand hygiene, and that means wash your hands with liquid soap and water properly for a good 20 seconds before you, and don't touch your face too much. That's going to do the majority of your prevention. So that works. Avoiding crowds does also work. It's just simply maths. If you're exposed to more people and more people are exposed to more people, the infection would spread faster. So if you just bear this in mind though, that only 0.0012% of the population are infected now, you have to get in contact with quite a lot of people before you're likely to encounter an actual case. So actually, yes, you don't have to avoid every crowd, but it does reduce your risk further. And good respiratory hygiene for others. If you're going to sneeze, cover your mouth with a tissue, bin the tissue, wash your hands. If you haven't got a tissue, sneeze into your elbow. It's better than just letting it free. And if everybody did that collectively, that would reduce your risk. What doesn't work? Surgical masks. They do not work, and the reason they do not work is because they are designed to stop the wearer shedding material and infecting others. They are not designed to stop you picking things up from the environment so much. So therefore your surgeon doesn't let that bacteria in their mouth contaminate the surgical field. After about 20 minutes of wearing this, it's saturated with water vapour, and a lot of air bypasses around the sides anyway. It may have some effect though, in that it stops you touching your face so much when you've got a mask on. So surgical masks are just, unless you are a sufferer yourself, don't work. If you are caring for someone who's a confirmed sufferer, there's a different type of mask based upon the FFP3 design, which has got a valve in and a filter. That's fine for short-term encounters for up to an hour, probably less than 20 minutes if you can, with somebody who's infected. They do work, but it's not practical to wear one of those all day. Surgical gloves, I can't see a reason why this will help, because whether you're touching a surface that's contaminated with your hands or with a glove, you can still vector it to your mouth. And if people who wear gloves all the time wash their hands less often. So I think you're denying yourself the main protection there. So surgical gloves are a no.
Right, am I at risk group? Is it an age thing, or is it about some pre-existing conditions? What determines this?
So we've looked at the stats of the cases infected in China and those who've died, and we've kind of built up a rough profile. Again, there aren't enough cases for us to be certain, but at-risk groups are the older, and we start seeing mortality rise at about age 50, and it increases as age marches on. The big difference is that most people who have died from it have got other long-term medical conditions, and by this I mean diabetes, they've got lung disease such as COPD, that's a big one. Kidney failure is another one. So it's your older adults with comorbidities are your at-risk people. That said, stats are limited, there's a lot of uncertainty around this. So I think as we get more cases, we'll get a better idea.
Are there any antiviral drugs that might help in the fight against this?
So it's a really good question, because back when we had the SARS and the MERS outbreak, there was a lot of effort invested into trying to find these. And you may have heard that in China they've been throwing anti-HIV drugs at the problem, the thinking being that HIV viruses are RNA-based viruses, as is COVID-19, so maybe they will work. We now have a bit of data on this, and it's basically drawing on the stats when they actually did clinical trials of this stuff back in the SARS days, and have repeated some of those trials now. They've found that there's a combination of drugs that they use for HIV, leponavir and ritonavir, these are protease inhibitors, used together may have some benefit. when they're used with a third antiviral, ribavirin, the proportion of cases who recover, so you get COVID-19, you get given these 3 antiretrovirals, now the recovery seems to be statistically significant, although limited. So, they seem to have an effect. There is one new drug that's being fast-tracked through called remdesivir, and this is a bit like acyclovir. It's a nucleotide analogue. And it was used for one case in America what was a compassionate case. They thought that the patient was sick enough to die, and he unexpectedly recovered. That's now sparked a clinical trial in China. That is ongoing at the moment, to be confirmed. So remdesivir, it is licensed, I think. It's gone through clinical trials. It's just not really been used in any significant population. We'll see what China stats show.
So once you've actually had coronavirus and recovered, will you be immune moving forward?
Short answer is we don't know. But viruses can change and mutate over time, and whether you become immune or not all depends on how fast they mutate and how much of the virus is recognisable to your immune system. Quite simply, it might be like chickenpox, where you see it once and that's it, you recognise it for the rest of your life. But it might be more like the common cold, where you have it 1 year and then it mutates enough that you don't recognise it and you get it again. We don't know where it is on that spectrum. We haven't had enough cases.
Here in the UK, what is our government planning to do about this outbreak?
So the government is doing what most governments do, and that is planning for the worst case scenario. Now, because we've got limited numbers of cases, we've got limited data, this is a new outbreak, we don't know for sure what's going to happen, therefore there's lots of uncertainty. The smart thing to do if you're a government is you plan for the highest worst case scenario. So people are hearing this and thinking, oh my god, this is super dangerous. Actually no, this is just the government covering all bases. So the main risk to the UK is that the NHS has a limited number of hospital beds. We've only got about 130,000 spare beds. All the others are full at the moment. We run about 90% capacity. So it would only take a proportion of the population, about if 1% got infected by COVID-19, if the hospitalisation rate was like it was in Wuhan in China, that would fill those beds up. And of course some of those cases would be staff, and that would reduce the capacity further. So that's what the government's planning for here. And so what they're doing is they're doing like a 4-step process: containment, then delay, then mitigation, and then research. And the idea is, let's try and stop this thing spreading, so advise people to self-isolate. That's your containment. And then you can do things in the delay phase if it does take a hold, tell people to work from home, you can limit large gatherings, etc. Mitigation, you can change the way hospitals operate, so they focus on firefighting, so you cancel routine operations, you cancel elective admissions, you draft in extra staff where you can, you have makeshift hospitals if need be. And then the research side, that's looking at doing things like we're seeing in China with new antivirals. So they're looking at worst case, but actually reality is it's not going to be as bad.
What is then the most likely scenario for how things might play out with this virus?
So I'll caveat this and say there's massive uncertainty here, and this is my own opinion based upon what I've read. And what I've read isn't all the data that's out there. There's a lot of data out there, although it's based on a small number of cases, so there's a lot of uncertainty. I think it's going to play out similar to SARS and MERS because it's a very similar virus, spread in similar ways. I think we will see the outbreak last for 4 to 6 months, similar length of time to the SARS and MERS. I think we'll see the mortality rate settle down to about 3.4%. And I think we will see a minority of the world infected. I would guess probably less than 5 million people. So that's the likely scenario. Your worst case scenario is going to be something a bit more like Spanish flu, where you have a significant proportion of the world infected, 27%, and a mortality rate of 3.4%, because we've got more certainty about that figure, which would be a significant number of people. So that's the worst case scenario. What I will say is the most likely thing that's going to harm you in the likely scenario is not the virus, but it's people's reaction to the virus. If people panic buy, they deplete stocks of important products. If they run to healthcare services prematurely or with infections which are not COVID-19, they can overwhelm resources, and they can then deny medical resources to people who have other illnesses and other needs. So we just need to be careful and acknowledge that actually sometimes the fear can be more destructive than the actual virus itself.